Good morning. Thank you for joining us for our Opioid Response monthly seminar. This is the kickoff to our fall series. We'll have four programs, always the first Friday of every month at 11:30 to 12:30. We had almost 400 of you register for today. It's a very significant day, as you know. It's September 1st, and September is Recovery Month. There are many, many activities across the state, and we have sent you all, everybody that registered got a list of almost 30 different events, and we hope that you'll make an effort to participate in events in your area. In recognition of Recovery Month, before we start the program today, I've asked the chair of our state's Substance Use Disorder Services Commission, Bruce Campbell, to speak for a moment on the importance of Recovery Month and what this means to the state of Maine. Bruce, thanks for joining us from the Augusta Recovery and Reentry Center this morning, and you take what time you need to share your thoughts with us.
Okay, thank you, Gordon. I'll try to be succinct because I know you got a really good presentation ahead of you. My name is Bruce Campbell, and I am the representative of the recovery community on Governor's Mills State Commission on Substance Use Disorder Services. I want to give a little bit of context, and I don't think that there's any argument that what went on yesterday at the International Overdose Awareness Day could be immediately followed up by the celebration of National Recovery Month. In 2006 and 2007, there was one event in the state of Maine. In 2028, there was the first Summit on Addiction Recovery took place in Bangor. It had 187 people attend. Last year, or earlier this year, the Governor's Summit in Portland had 1,400 people attend. So the dramatic increase in support for recovery. And if you were at that summit, you saw how much the recovery community was valued and supported in that presentation. In 2009, there was one recovery community center in the state of Maine. By the end of 2023, there will be 21 recovery community centers throughout the state of Maine. In 2007, there was one celebration, and in 2023, there are 29 celebrations throughout the state. You received this in your email. Please feel free to distribute this wherever you like. We're represented in recovery celebrations from Aroostook County to York County. There are now recovery community centers from Aroostook County to York County and all counties in between. I want to applaud the leadership that this administration has shown, and I applaud all the recovery community centers and the recovery community itself in demonstrating that the power of recovery and the power of connection is one of the best tools we have in our tool chest to deal with this opioid crisis and all the other substance use disorders. With that, I'll pass it back to you, Gordon, and thank you all very much for giving me a couple of minutes here.
Thank you very much, Bruce, and thank you for your leadership of the commission, which is a statutory body. You're all volunteers and have worked very hard to reorganize yourself, and we appreciate your leadership. The program today, as you all know, involves some important initiatives with our partners at the Office of Emergency Medical Services. A lot of our work, a lot of the work on the ground but trying to keep people alive is done by these heroic EMS technicians and services. We're led now over there by Sam Hurley. Director Hurley's organized a powerful public health team over there. And Megan Salois is going to do the presentation of some of their new initiatives that are directly involved with substance use disorder. Megan's title there is the Substance Use Disorder Response Program Manager. She's been there nearly a year now. She's a licensed social worker, a certified alcohol and drug counselor, has a bachelor's degree in psychology and a master's degree, and is working on a second master's degree in public health. We are so honored to have her today. We're so pleased with the growth of the public health team over at the EMS office. And Director Hurley is also available with me to assist Megan in answering any questions. I'd ask that you put any questions in the question and answer box. The way my Zoom is set up now, I have to go over to a little box that says more and click on that before I find the question and answer box. I don't know what your particular screen might be, but put any questions you have in there. If we don't have time to answer them by the end of the session at 12:30, we will answer them in writing and put those on our website. So Megan, I know you've got a presentation. I'm so appreciative that you take some of Friday before a long holiday weekend to share these exciting programs with us. And with that, I'm going to have you kick off our fall series.
All right. Thank you so much, Gordon. It's a tremendous honor and appreciation to be here and share our programming with you all today. So I will share my screen so we can get started. Again, we're here to talk today about our program here at Maine EMS on our work on our response to the ongoing opioid crisis in Maine. If some of you were at our presentation last December, we had just really gotten started with some of our programming. We had a very new team. Now that our team has really grown to a much more robust and capable level of meeting all of the needs and challenges that we wanted to accomplish as we get going in our programming, we have a lot more exciting updates to include for you all today. So today we're going to talk a little bit about our Maine EMS data, a brief overview, some basics on the analytics and evaluation tools that we use, and some of the surveillance tools as well that are in place. The data, of course, is incredibly important and integral to our processes as it helps guide our insights, guiding our programming, guiding strategies, giving us better pictures and experiential knowledge and qualitative knowledge of what's happening in small, medium, and large communities around Maine. And we will also be doing the overview of where we're at with our current EMS SUD programming. So that includes our ambassador program, our Naloxone Leave Behind, the options referral pilot program, and the medication for opioid use disorder program. So to get started on the data front, our data comes directly from the field and our EMS clinicians and their tremendous work that they do every day. The run reports that they complete give us so many different clues and pieces of information to what we're seeing, gives direct guidance and reports back on what people are seeing and experiencing for a variety of medical encounters, but namely for our purposes, the substance use experiences and encounters that our EMS clinicians work with every day. This includes patient care reports, of course, and within those, the fatal and non-fatal overdose information, reversal data from naloxone being administered, different comorbid components of that, including medical issues, psychological or psychiatric encounters, and any other elements that can be present in addition to the substance use. Our system with our data is defined and given parameters based on standardized elements. So these are elements that are universal through the state. Every EMS clinician from Fort Kent to Saco, Kittery uses the same run report. So it gives us standard universal information from different data points, but using all the same language so we can best interpret it and utilize it. So I'll go through a little bit of what some of that data from these run reports and other sources through our EMS system turn into. Our data team at Maine EMS is a unbelievably valuable resource, and we're very lucky to have them at our fingertips. But they help build us, from all those data points, build us these really useful tables, charts, and other data sets that we can use to build insight and use to strategize. So this is a visualization of EMS responses to suspected opioid overdoses from the last 4 years to date. Of course, we'll have 2023 data to date after December 31st this year. But this gives a visualization of the, in yellow, suspected opioid overdose increases. In green, the naloxone administered prior to EMS arrival on scene. The orange being the respiratory arrest and or depression with naloxone administered, and the blue on the bottom of the cardiac arrest with resuscitation. So you can see where the blue is fairly stabilized. The orange had a little bit of an increase, but you can see the big increases in the naloxone administration prior to EMS on scene and the suspected opioid overdoses. So the naloxone administered prior to EMS in green has continued to climb, which we see as a positive, as well as the suspected opioid overdoses. And this data set is somewhat stabilized while still elevated, and we'll know more at the end of this year. But we're still seeing around the same year as last year, trending amounts of overdose and volume of calls. This gives a snapshot over the past 12 months from about this time last year to opioid patients with EMS, their disposition on calls, looking at whether they were a fatal overdose, deceased in the black along the bottom of that chart, up above that of the red of a patient declining care. So this may be, we're on scene, we've reversed them with naloxone, they're declining further transport or care at that point. The line just above the blue line just above the red, is a patient who's been treated and evaluated but not given transport, which has been a bit of an up and down depending on the time of year. And then, of course, the green up atop of patients impacted by substance use that have been transported, which is also a quite up and down line as well. So it's hard to predict necessarily when people are going to want to be transported or not. People have many different reasons for declining care, declining transport to a medical facility, but we track a lot of those trends and reasons why, so we can again better strategize building toward the future of our programming. We track the reasons why patients decline care. We track different areas of the state that might be happening more or less to figure out what we're dealing with and how we can better support EMS clinicians and patients alike. This data analytics map serves as somewhat of a heat map. This is a capture from the past year, 2022. To date, the 4 major urbane areas of Maine continue to be the more focal points of opioid-related substance use encounters for EMS clinicians. So you can see at the bottom there, the hub, the primary area of opioid overdose and encounter calls occur in Portland, Cumberland County, where the highest density of population. Secondary to Lewiston, Auburn area, where is also a very high urbane area, very high population density. Third to a little bit further up in Bangor, Bangor being a very large urbane area, but also with some more rural components, makes for a more complex picture when we look at available resources and utility of transport versus non-transport in medical facilities and behavioral health resources. And then lastly, right here in Kennebec County, between Waterville and Augusta, still a somewhat more urbane area than our surrounding areas, but smaller amounts of volume and calls, more rural areas, less resources, and considerations for that rural versus suburban versus urban population mix. We utilize this to strategize approach. We utilize this to keep an ear to the ground on trends, on possible spike alerts. The CDC communicates with us as well on their biosurveillance, so we can coordinate efforts and have a situational awareness of what another is looking at so we can best plan ahead. This type of map has been fairly stable over the last few years throughout the COVID pandemic. Things have unfortunately remained fairly high in these specific areas. The outlying green areas are still areas of need and volume, but not to that same level of the red or orange, of course, signaling that high volume and level of urgency. This is yet another one of our tools that we use to track data and dispense our insights from that data that we receive. This is a monthly dashboard that our data team puts together that incorporates information we get off the patient care reports. And you can see this disposition chart in the bottom left is similar to what we just viewed. That data gets updated on a monthly basis. So we have a substance use overall dashboard like this and the opioid focused dashboard, but they have similar information. So this looks at the percentages up in the top left with how many overdoses had fatal outcomes, how many overdoses included other influencing factors such as pregnancy, homelessness, sometimes psychiatric encounters or mental health's included, other medical conditions, anything that might add to the impact of overdose for our tracking. We look at naloxone doses administered by our EMS system. We take into account when opportunities for naloxone present. We look at if naloxone was administered prior to EMS arrival, all of those things. In the bottom right corner, we look at where these encounters have occurred. The types of encounters tend to be fairly stable. They may vary in terms of percentages month to month. Of course, we're headed into the colder winter months, so that impacts our folks that are unhoused. We might see more folks out in the elements or trying to seek shelter in other places. So they give us additional insight on those things as well, depending on weather. This is the second half of that monthly dashboard where we look at suspected opioid overdose rates per 10,000 population by density by county. In the top left, you can see the visualization of that by the maps, by the counties within the map, by county. We can look at, again, suspected opioid overdose, because when our EMS clinicians arrive on scene, we don't necessarily know it's specifically opioids or just opioids. I think it's fair to say the polysubstance use risk is high given the current drug supply and complexity of synthetics on the market, unfortunately. But we use the term suspected, especially based on symptomology and presenting assessment by the EMS clinicians, and of course, response to naloxone reversal. Now, the bottom half of this dashboard, we can look at the suspected opioid encounters by age group and gender. So again, this is another data set that tends to ebb and flow slightly, but for the most part, it's been pretty equally distributed between male, female patients. And the highest level of prevalence has been that age range between 30 to 50 on the bottom. It might be hard to see from where you're sitting. It's fairly small font, but it's a high area of prevalence due to a lot of lifespan considerations between that 30 to 50 age range. That age range might vary as well, but tends to be a fairly stable data set, more or less a small margin. And so, of course, any other data questions you may have, please let us know, and we're happy to give a more detailed overview. I just want to make sure we get through everything else today. So any additional data questions are welcome. So as we get started talking about our programming, from the SUD team, one of the first things we wanted to touch on was our ambassador program. The full name of the program being the Maine EMS Substance Use Disorder Care Ambassadors, was a shorter term program we launched earlier this summer with a small team of 4 individuals that have current and or a past emergency medical services experience working directly in the field. We wanted to design a team that would work directly with service leaders and EMS clinicians in the field to provide some outreach opportunities and education about our programs, namely the Naloxone Leave Behind, the up and coming programs with options referral and the MOUD, talk about stigma reduction, and talk about other ways to help support our EMS clinicians as they take on SUD programming into their day-to-day practices of care, where we seek to reduce that stigma against people experiencing substance use. We're seeking to provide a new skill set, as Bruce even mentioned earlier, of tools. We want to provide our EMS clinicians better tools to have on hand when they encounter a person experiencing substance use on their calls. So this team of 4 individuals were contracted under our team to provide this outreach, meet with service leaders and EMS clinicians to provide education on our programming, and have those really important but sometimes challenging conversations about stigma and substance use, talking about addiction and talking about any barriers or concerns clinicians might have as they embark and start to adopt these programmings. So the program launched, deployed our small team of contractors the beginning of July. We've actually concluded part of the phase of this program as of yesterday, August 31st, Overdose Recovery Day. Overdose Awareness Day headed into Recovery Month, as it so happens, but the full data of that we're still working on compiling and organizing, but some of the preliminary numbers that we've seen have been very helpful and conducive to our programming. Over the course of the past several weeks, our team of 4 ambassadors made 121 contacts with EMS departments around the state throughout several counties via email and phone contacts, which resulted in 15 department meetings with EMS agencies as a result of all those outreach attempts. 25 unique EMS departments were represented in those 15 meetings. So we had multiple departments represent at those meetings, which was also a really great opportunity to hear from your peers as a mixed meeting of their experiences and their insights and questions, and some of their feedback about their concerns and thoughts about what stigma reduction really means and what addiction really means and how these programs can help our EMS patients have some better outcomes, but also have better outcomes for our EMS clinicians, where working any call in any kind of helping profession over time can have a compiling effect of frustration or wanting to be able to do more, see better results, and wanting to feel more helpful. And the underlying hope of these programs, in addition to benefiting our patients, benefits our EMS clinicians, that they can have these tools to utilize and have that feeling of greater success and ability to help in a larger sense. And in that same light, since the deployment of the ambassador team over the past several weeks, we had more EMS agencies sign on to adopt the Naloxone Leave Behind programming. We had 18 agencies, in fact, in the last few weeks sign on to begin that training and start that process, which we'll talk about the Naloxone Leave Behind in a moment. But the ambassador program provided a unique opportunity to connect our team with more of our EMS clinicians and service leaders directly with these EMS professionals as contracted ambassadors to make that liaise between us and our providers every day, but also have those really difficult conversations with people that have experienced the same things. These ambassadors have worked in the field and or work in the field and are able to share that, have walked in your same shoes sentiment with our EMS clinicians, which really lends to a great level of validation and understanding, and also comfort to talk through a lot of these things. And in the for the future of our programming, we intend to keep that going. Right now, we've wrapped that current phase, as I had said, as of yesterday, August 31st, but we intend to really circle back with the data that we've collected over the last several weeks, look at our programming, and look at how we can re-implement the ambassador program early next year to continue their outreach efforts, continue education. Education is a tremendous foundation of what our SUD team wants to continue, of having these really important conversations. Is sharing information is helpful in providing education, but also the opportunity for our EMS clinicians to share their insights, their perspectives, and their questions and concerns have been very helpful to talk out in these trainings, as well as organically obtained conversations from those meetings that our team has had with EMS clinicians too, providing more of a platform to talk through these things. These programs are newer, and thinking through recovery, offering better resources, thinking about addiction in a less stigmatized and more normalized light is a years-long process, but the ambassador's strategy is one that will help us continue to work through those efforts. So that leads us into our Naloxone Leave Behind programming. So the Naloxone Leave Behind program deployed almost a couple of years ago to date, December 2021. More recently, we had the legislative action LD 981 come through that will make the Naloxone Leave Behind a standard practice of care rather than more of a elective adoption of services. So this states that EMS clinicians, when they reverse a patient on naloxone, their part of their standard practice of procedure and care will be to offer to leave naloxone and the accompanying literature on naloxone and recovery sources with the patient's bystanding friends or family, so that if they've declined transport, that they have another opportunity to re-administer Narcan naloxone if they need it. They have resources to connect with care if they change their mind. The naloxone gives a person a second chance at survival to be able to make those choices for themselves when they're ready. So this new standard of care goes into effect officially on December 1st of this year, 2023. So that's part of why the ambassadors keep proliferating the growth of the Naloxone Leave Behind program with this up and coming standard of care, but also as it's still been an elective, but a growing program, keeping people informed, keeping people updated on its efficacy and how to implement this and how it's used. This is a little bit of an overview of how the Leave Behind works. The program is designed for people that have declined or refused transport to the hospital or a medical facility for further care, that without that transport, they might miss out on opportunities for further resources or access to additional care. The naloxone that is dispensed, that is the Left Behind kit, is the 4 milligram nasal atomizer, or that accompanies the literature. We wanted to continue to make our programming as low a lift as possible for our EMS clinicians. That's something that's easy to use, easy to implement, easy to monitor and manage, and that also has efficacy. So to get our EMS agency started on this, we require a brief online training on our MEMS Ed, our asynchronous learning platform. It's about an hour-long training that EMS clinicians can complete. We're happy to support agencies through that process as they need any assistance or have questions. And we direct them to the naloxone resources to access through the Tier 1 distributors to access their naloxone and the literature that goes with it. A lot of questions that we've gotten is about the cost. Maintaining sustainability is, of course, a major concern for most folks. So we've ensured people the federal funding is still in place to supply the naloxone and literature for an extended length of time. So it's a free to implement. It costs you a few moments of time on a call, just as you're doing the documentation on the declination of transport. That's the perfect window of opportunity to offer this resource. And it really serves as the foundation of the pyramid of resources, the toolkit of resources that we're building to hope for better outcomes and give people more opportunities with substance use encounters rather. So just to give an update and overview on some of the numbers, we're seeing approximately 22% of EMS patients that decline or refuse transport to medical facilities after being reversed on naloxone or Narcan. For every 100 opportunities to leave naloxone behind, 18 attempts were made. The attempts and the balance of adoption of this program is still in flux. We are headed towards that standard of care coming of December 1st. But in that, we're still doing a lot of education, a lot of communication and conversations with our EMS clinicians and service leaders so we can talk through some of the challenges or barriers people have been experiencing that might affect those that number of attempts made versus the opportunities. So something that we really want to make sure we highlight is the efficacy of these opportunities. So as you can see here, based on the graphic of the almost full person and the 4 3/4 people on the right, that every time a naloxone leave behind kit was left behind for a patient, the fatality rate of that patient suffering a subsequent overdose is less than 1%. Officially, the number is 0.7. So very, very low rate of fatality for when that kit is left behind, versus when a kit was not left behind, the rate of a fatal outcome for a subsequent overdose was closer to 5% at about 4.7%. So it might seem like a small number, but when you look at the number of individual lives that can help spare, can help get a person to see another day, people most of the time don't intend to overdose, and it's a very scary and sometimes very humbling experience. We want to be a support for people experiencing that when they feel ready, when they feel capable and have what they need at their fingertips to access those resources, that we've given them a chance to do that. And that's what the naloxone offers. By itself, it won't resolve the opioid crisis, but it's a tremendously important piece of harm reduction and opportunity for education to lend to that endeavor. So if any of you were present for our presentation last December, this is a familiar slide, but we wanted to revisit it just as a reminder and also a general overview for anyone that has not heard about our pilot program. So our next level up from the Naloxone Leave Behind program is the Options Referral Pilot. We partner closely with the Options Initiative out of the Office of Behavioral Health, Options standing for the Overdose Prevention through Intensive Outreach Naloxone and Safety. They're a tremendously valuable partner that we work with to balance out that access to resources, particularly, again, for that 22% of folks that refuse or decline transport to a facility where they might have access to an options or a similar referral. So as a general overview, the Options program has liaisons based in all 16 Maine counties. Some embed with law enforcement and other first responders, some dispatch out after, some come directly from referral systems that they get through the Options website. So depending on the county, that might look differently, but they are a great resource in every county that serves as a mobile responder, as a behavioral health mobile responder to connect with people that might have limited resources or means to connect with recovery services. So the pilot for this has launched since July. We've built, as low of a lift as we can for the referral process that's still HIPAA compliant, but easy to use, expedient and efficient and concise, so we're not spending a lot of time with paperwork and sending things this way or that. That's a very condensed and concise system. So how we've built this referral directly to our options liaisons is right into our patient care report, the run report that our EMS clinicians complete on scene. A patient is able to sign that consent right in the EMS clinician's run report. They ask a question of whether or not they would like this consent for this explicit purpose. They sign off, just as they would sign off if they were declining or refusing transport. Once that patient care report is completed, it gets sent cloudlessly, seamlessly through our SharePoint cloud. So there's no faxing or scanning referral documents or calls or emails that might be less secure. It goes directly to a secured SharePoint cloud access that our options liaisons and our team has access to. And the options liaison has the 48-hour window to link up with that patient post-referral. So right now we're running the pilot of this with a fairly small amount of agencies to test the system. The options program is undergoing an expansion to offer more liaisons per county to help meet the growing needs of substance use and for our purposes, of course, opiate-related encounters. So we're planning to run this through the end of November of this year with up to 6 agencies of different areas of the state, different rural or more urbane areas to trial out the different levels of need and adopters of the naloxone leave behind to accompany this referral process. So currently we have a site in Hancock County, and we're in the process of onboarding 2 other services in the Oxford and Franklin area and the Kennebec County area. We're in the process of preparing onboard for an agency in Cumberland and have room for another 2 agencies that we'll be planning to bring on in a subsequent cadence to collect a robust set of data so we can plan ahead for an expansion process. It's important that we trial this out because we want to make sure we're delivering on this referral system to our EMS patients as well as our EMS clinicians. We want to work closely with our partners in the options program to ensure that they have what they need, working within that 48-hour window, and having a new access route to patients that they haven't previously had as much connection with. A lot of options referrals have come through law enforcement and other means, and they're opening up to be able to connect with more of our EMS patients. So it's advantageous for all. And again, it's another one of those tools that we hope will help offset some of that frustration our EMS clinicians might feel at times when they only have had naloxone leave behind to utilize without the ability to offer more to a patient that would really benefit from a quick conversation of, we have this referral system and someone can reach out to you in a couple of days to get you linked up with some resources. How does that sound? It can make a really big difference for people in addition to the naloxone leave behind. So we have a lot more data to collect from this phase as we look at expansion and what that strategy will look like. But we have a tremendous partner in the options program and the Office of Behavioral Health. We're very excited and motivated of what that will look like. And the pinnacle of our substance use disorder programming is the MOUD program, the Medication for Opioid Use Disorder, sometimes referenced as MAT, Medication Assisted Treatment. The medication for opioid use disorder, primarily Suboxone or buprenorphine, is what we plan to implement in a future program coming next year. This is still in a request for proposal RFP process to bring on medical direction support, which is integral to the design of this program. So we can build a pilot, we can build the protocols and the standards of care that will accompany this. There's a lot of logistics that come with a program of this design, so it will take a lot of consideration. And even in the ambassador meetings and meetings we've had with agencies and clinicians, we've garnered a lot of really great questions and concerns that have been brought forth to us that will also help as we build this. So as we look at MOUD, it lends to that destigmatization effort, because as much stigma surrounds substance use disorder, there's also a lot of stigma around some of the tools that we implement to combat the opioid use disorder needs. Suboxone has the benefit of incorporating naloxone in its chemical compound. So as we reverse someone on naloxone itself, being able to initiate someone on Suboxone in the field, getting them right on that first dose, helps further prevent that person going into more overdose symptoms later on, depending on the chemical compounds they've ingested or have utilized, with the buprenorphine that helps serve that complex brain activity, those feel-good hormones and chemicals that drive us to remain in our cycle of use. So this, again, is meant to serve folks that have declined or refused transport to a hospital, that might have access to connectivity to care otherwise, but without that transport, they really miss out on those additional resources and connections. So this program, again, helps better access that 22% of our patients that miss out on those opportunities, giving a more direct pathway, giving our clinicians better and more efficient resources to lend to that reduction of overdoses and fatal overdose calls, and hopefully reduce the likelihood of somebody suffering a subsequent overdose after we've reversed them. This is another great harm reduction method, as well as a response method, in alignment with our Governor Mills strategic action plan. And the hope is that once we've accomplished this program design, we've accomplished a pilot phase over the next, in the next year, that we can be mobilizing this on that grand scale for the entire state, in every county. The connectivity care is a big thing. Access to medication-assisted treatment and medication for opioid use disorder is sometimes very challenging given the resources that we have available in the state of Maine, and certainly rural areas of Maine. So this serves as that apex of tools that we can offer in our SUD programming and rollouts. That this will be an initiation of Suboxone on the scene, not dispensation, but initiation and accompanying a referral to ensure that ongoing long-term care, all by a person that we can encounter in the community that might not see a behavioral health clinic or primary care or an emergency department, and give us better, stronger response efforts. So again, as we get more information about that, as we continue to build that, we'll have more available, but mostly that encompasses our vision, what we hope to achieve, and we feel that fully packaged SUD programming toolkit will make some really tremendous impacts for our patients. These are our team's contact information and names. We're proud to say that we've grown from a very small team over the past year to a fully staffed team, a very robust group of professionals with tremendous experience, valuable perspectives from different disciplines. And we also have a centralized email inbox, ems.sud@maine.gov, that we all have access to have more expedient direct access to us as well for any questions, concerns, offering to have any conversations or discussions with anyone that would like more information than what we've gone over today. And forgive my brevity in certain aspects, but wanted to make sure I got everything out through the time frame today. And thank you for the attention through that. But we welcome any and all questions or concerns or further desire for information.
Well, thank you very much, Megan, for that presentation. You presented 4 really exciting projects, of which the 4th, as you say, will hopefully roll out next year after more medical direction is purchased and found. That would really be the more cutting edge of the 4 programs. the Suboxone piece. We had a lot of questions. I tried to keep up with them. If you could stop sharing your slides, so that you and I will be on camera. And Director Hurley, you should feel free to come on camera if you'd like, because you're gonna have to answer some of these questions. I think there are many good ones. Let's see. Let me just pull them up. I answered some as we went along, but let me ask the questions, and then you and Megan can sort out who answers them. One from Senator Moore. Marianne, I hope you don't mind me mentioning it's your question. It's a great one, and you've had a role in the legislature on this. Senator Moore's question is, are there any plans to get other FDA reversal products out to the field in view of the synthetic drugs appearing in the field these days that do not respond to Narcan? I'll take a stab at that, in that the other drugs that people might fatally overdose from, such as stimulants, xylazine plays a role. The non-opioids, you're right, do not respond to Narcan. The bad news is that there isn't a reversal agent for those other drugs. Am I wrong about that, Sam?
You are correct, and that's part of the problem, is that there isn't a reversible agent for those particular drugs. I know that there was legislation that was proposed in this last session that would allow for other medications to be used in the field rather than Narcan. There are some other medications that I'm sure many people are familiar with that have longer half-lives, etc. However, we haven't necessarily seen evidence that suggests that it works better than Narcan in the field in this context. And particularly for EMS, we do not administer doses of 4 or 8 milligrams. We're administering doses of Narcan at 0.4 milligrams because our intention is to titrate that dosing to the desired effect, which is resuscitation of the person and their breathing. I am not necessarily trying to wake them up per se, but I want to make sure that they are breathing on their own, etc., because I don't want to put them in precipitated withdrawals. And so we actually give much smaller doses of naloxone.
You may be relating to that next question that I was about to read, saying, does the dose of Narcan used by EMS, does it vary statewide per service? What are the protocols? It doesn't vary, does it?
Yeah, you're exactly right. The dosing for the state of Maine is 0.4 milligrams per administration. So the idea is to titrate that to the desired effect, which is return of spontaneous respirations. We do not use the auto injectors for our life-saving efforts. So if you dial 911 and an EMS clinician arrives on scene, there would only be one situation where we would use the auto inject the nasal sprays, and that would be if they're emergency medical responders. They potentially may have some nasal spray. However, for the most part, and for all intents and purposes in this conversation, EMS clinicians are dosing it at 0.4 milligrams each time.
I just want to make clear that you're talking now about what they administer, not what they distribute.
Exactly. What they are dispensing to patients and families are the 4 milligram kits. So it's 4 milligrams in each of the sprays.
Right. And to get back to Senator Moore's question a little bit, because there was so much attention even yesterday during International Overdose Awareness Day of the announcement that next week the over-the-counter naloxone will become available in many Maine pharmacies, and they announced the price point for the first time. which is $45 for a double dose. That's frankly better pricing than I expected off the shelf. But in our interviews yesterday, we made clear that the availability of that, which we're very supportive of, and believe that it will assist in our naloxone saturation efforts, it's not going to change our public distribution to the audiences and the groups of people that we're trying to support. We feel that the people, honestly, that are most vulnerable, that, presumably most of our 330,000 doses have been distributed to, are not people that are honestly going to walk into a pharmacy and lay out $45 for the kit. They will continue to go to the syringe exchanges. They'll go to our recovery centers. They'll go to community organizations where we have been making this available without charge to keep people alive, and we absolutely intend to keep doing that. So I see the over-the-counter piece as kind of an enhancement for people, for many families that may not be comfortable going to a syringe program or a recovery center, or even to ask their pharmacist at the counter about it. If they can just go in and buy it like they do a can of deodorant and have it available in their home, that's a wonderful thing that will save lives. Let me see what else we've got for questions, because we've got almost 10 minutes still left. Sam, this is for you or Megan. Do you anticipate widespread, this is to next year's program on Sublocade, do you anticipate widespread distribution of Sublocade? Well, maybe it's a question for me, because they may be, I can't tell whether they're talking about Sublocade, the injectable version of Suboxone, or whether they're talking about Suboxone. Let's assume, though, that they're really talking about Suboxone. And do you anticipate widespread distribution next year once that program is up and running, widespread distribution across the state?
Yeah, so Megan might be the best to answer this, but my expectation is that we will initially start with one agency, get them up and going. We really want to make sure that we have all the kinks worked out before we are going widespread, and that we have a transitionary pathway by which, once we initiate someone on Suboxone or MOUD in general, whether we attempted to try Sublocade rather than Suboxone or in addition to Suboxone, we want to make sure that we have a pathway by which we can easily transition them to care. We have developed multiple models in which we can continue that care through the EMS system, but ideally we would like to be able to transition them to local clinical care in their area as quickly as possible, so that EMS doesn't become the de facto treating clinicians for these patients in the long term. Our plan is to ensure that we have pathways to continue care for up to 2 weeks, but we anticipate that we should be able to make that transition within that time period. As far as the widespread deployment of this model, I anticipate that it'll be slow. We want to make sure that we work out all the bugs that may be within this system, within this project. But I am optimistic that we will really work to expand coverage and applicability, particularly to our rural areas that may not have access to treatment and resources. That will be our top priority, is really focusing on those areas where there is for a no better word, somewhat of a treatment desert.
I want to get at a couple questions, one for you or Megan, which deals with, well, I'll just read it. Is there data on the extent to which best practices such as these are adopted by EMS services in the various counties? Would it be helpful to better understand coverage and vulnerability within and between counties? So one one of you could address, you know, the efforts that have been made in the state and the legislature to shore up our I don't want to say that our EMS system is crumbling, but it has great vulnerabilities in those rural areas for the workforce shortages, the things that everybody knows about. So let me turn it over to one of you to say, does that result in some challenges in having these best practices be uniform across the state?
Well, I'll let Sam speak to the greater shoring up of sustainability on a statewide, but as we look at approaching these, the options referral and the MOUD pilots, that's part of that slow progression forward to make sure we're testing out any barriers or gaps to keep those as tightly confined while we work through those and think critically on next steps forward. That the low lift, as much as we can make a low lift on implementation, the training to implement these programs, and the sustainability financially, like the Naloxone leave behind is no cost to our EMS agencies. The options referral processes of no cost. The trainings for both of those are no cost. Part of the long process of building the MOUD pilot and programming is ensuring that what that cost would look like, what those logistics will look like, because it's a much more complex program. And as Sam said, that's likely going to be a very slow process, slow but steady and cautiously preventative and proactive process as we look at all of the different aspects of that. But keeping things at, for the cost, the sustainability of access to supplies and or resources, and the accessibility to our team to help provide that support for onboarding to the trainings and other support that goes along with the implementation of a new program.
Anything to add there, Sam?
Yeah, and the only thing I might add is that there is significant as far as a novel process. There is data regarding the implementation of programming like the MOUD initiation by EMS clinicians from other agencies, counties, throughout the United States, California, New Jersey, and people are actually looking to us for what we have developed here in the state of Maine as a package. I'm in DC at a substance use disorder conference here in the district, and literally we spoke about what we were doing, and someone came up to me afterwards and said, this is literally visionary work in this area, and it's all thanks to the incredible team that we have at Maine EMS for coming up with these ideas. But there is data to support the best practices that we are putting forward, and I do think that there are, and I see it in the questions, which we actually heard a presentation from Michigan about a vulnerability index and using data to better understand where should we expand this coverage, where should those pilot sites be, where should we be focusing on vulnerabilities. And I think that's an excellent idea and something that we have actually spoken with Michigan about how we can do the similar process with them to assess vulnerabilities in communities throughout the state.
Hey, I'm going to take one, it's 12:30, but I'm going to take one more question because I think it's important that one of the listeners has asked whether there's public data that shows how many doses of Narcan are being given out by each of the hospitals to people who have survived an overdose when discharged from the emergency department. We don't necessarily have that in front of us, but I can tell you that the Clinical Advisory Committee has advised all the emergency medical directors of the emergency department of what is expected of that emergency room. We expect them to, in fact, provide low barrier access to Suboxone, and we expect them to offer naloxone when people leave the facility. So it's an expectation we've created, whether or not, obvious EMS, their kind of responsibility kind of, for the most part, stops when they get to that hospital door. So we can't expect Sam to know the end, or Megan to know the answer to that question. But we will ask the hospitals a question and try to post the answer on our website when we have it available. So these other questions, they're really good ones. And we will absolutely, work with AdCare to get the answers on our website. So, and maybe, Lorena, we can notify people when we know that that's been posted. I want to thank Megan and Sam for being available today for the presentation. I want to thank all of you who have taken, a Friday before Labor Day weekend to join us. Our next webinar will be October 6th, and I'm hoping that those next three this fall might include something from the Overdose Review Panel. It's a statutory panel, wonderful group of people that do deep dives into individual overdoses, fatal and non-fatal, to learn about what happened and in this person's life from birth until death. I think that would be of interest. I want to talk to the Northern New England Poison Control Center and see if they do a presentation on how their data intersects with our substance use disorder issue in the state. They do a great job down there, and they do have some good data. And maybe we have a new harm reduction learning collaborative that might be interesting, might be available by the end of the year to tell us some of the things that they're working on. So we appreciate the hundreds of people that participate in our regular webinars. I want to wish you all a great Labor Day weekend, and hope to see you all on October 6th. Thanks again, Megan and Sam.
Thank you. Thank you, everybody, for listening, and let us know if you have any questions.